this presentation on CPAP and the introduction to the Rescuer II CPAP system. So CPAP in itself started being used in the late 1990s as a primary form of non-invasive positive pressure ventilation that would help prevent patients needing intubation with an endotracheal tube or the use of supraglottic airway to provide ventilations. CPAP is really great because it helps provide a constant level of pressure in the upper and lower airways and helps facilitate gas exchange with this constant pressure and air intake. So when we look at how our air moves across our alveolar membrane, the primary law for diffusion of oxygen across an alveolar membrane is Fick's law of diffusion. So we look at the rate of diffusion. Under Fick's law, there's three big things that's going to affect the transfer of oxygen in and out of the lungs, as well as CO2 in and out of the lungs. So with that, the first thing we're going to look at is the pressure gradient. So the higher the pressure gradient, the greater the transfer of gas, and the pressure gradient must be maintained for gas exchange to continue. The maintenance of this gradient is achieved by adequate ventilation, so whether with CPAP, positive pressure ventilation, so that we get that constant pressure of air into the alveoli to refresh the alveolar gases, allow oxygen to get in, and allow to flush out the CO2. The next thing that's going to affect our diffusion of oxygenation across the alveolar membrane is the surface area of the membrane. So the greater the surface area available for gas exchange, the greater the exchange we have. The lung has a very large surface area alveoli, which is great for gas exchange, but when we start having problems with the size of the alveoli, that can affect the transfer of gases across that membrane. The third thing we're going to look at that affects gas exchange across the alveolar membrane is the thickness of the membrane. So this also determines the rate of transfer. So the thinner the membrane, the more rapid the transfer. The gas exchange membrane in the lung is approximately 3 micrometers thick, and it really allows a lot of gas exchange. So some things that we're going to discuss can affect the thickness of the membrane that can slow down this transfer of oxygen and CO2 across the alveolar membrane. So when we look at the effect of CPAP, when we consider these three parts of Fick's law here, is that when we have someone that has COPD or pulmonary edema, they have some of the following issues. So you can see in the diagram here, a patient with pulmonary edema have fluid blocking the airway, and that's shown with these little orange circles here. So that's fluid buildup in the lungs. So that's going to increase that thickness of the membrane because now it's got to get through the fluid and the alveolar membrane as well. So that's going to make it harder for gas exchange to take place because that's in the way. Also, like patients with COPD, their alveoli may be constricted or damaged. That reduces the actual membrane availability as well and the size of the surface area. So the big thing we're looking at as well is that oxygen, how much actual air pressure is going into the lungs. If patients are having a lot of trouble breathing, that's going to cause a pressure gradient difference, which can cause that fluid to move into the lung space and as well as decrease the amount of CO2 that is able to transfer across those cell membranes. So when we look at adding CPAP, when it's applied to a patient, it can cause a significant increase in alveolar oxygenation up to 5 times. So that pressure we're getting put into the alveoli increases that effect on the atmospheric pressure, which helps to open up the alveoli, which increases the surface area, which aids in the diffusion of oxygen and the subsequent release of CO2. The increase in pressure and surface area as well reduces the thickness of the alveolar membrane, which will help to counterbalance the interstitial or capillary pressures and will slow or stop the movement of fluid into the alveoli, causing reduction of fluid in the airway. So as you can see in the diagram here, we've got that increase in pressure, we've got more surface area, which improves that diffusion of gases. It helps switch the pressure gradients to help fluid go back into the body and out of the alveoli, and it helps us to get rid of CO2 a lot easier as well. So when we look at these gas laws here, this is why we want to use CPAP for these patients. That has a lot of benefits just to help with the oxygenation and the elimination of CO2. So this is a CT here. So this is CT slices of the lungs, so bases of the lungs of a patient with COPD. So the green parts that are shown on this slide here, those are areas that have been opened up with the use of CPAP, so they're hyperinflated. As you can see with lung sections A, it doesn't have any CPAP, so the lungs on the left isn't as bad. The one on the right is pretty shut down. But as you can see, as we increase our CPAP, with CPAP of 5, there's a bit of improvement, but the big one is when you start looking at 10 and 15 centimeters of pressure for CPAP. There's a lot more, especially in that right lung, a lot more area opened up on both lungs. You can see the green areas have opened up. So with CPAP, it just helps hyperinflate and open up more alveoli. So the increase in that alveoli availability and that surface area enlargement allows for greater gas exchange, so it allows our patients to get the fluid out of their lungs. It helps them get more oxygen in and subsequently better elimination of CO2. So as per our care map, as per P01.1, so the new procedure document, along with E08, heart failure and pulmonary edema, we're going to talk about when we use CPAP. So the indications to use CPAP, the ones that have the definitive benefit, these are ones that are proven that to help, is patients with acute decompensated heart failure, or ADHF. And when we look at our acute decompensated heart failure here, so we have our patients with heart failure. So in this little chart here, it shows increased perfusion, increased congestion. So your patients may have either way when it comes to heart failure. They may be wet and cold or wet and warm. And when it gets to the wet part, that means that they're getting fluid buildup in the lungs. That's kind of where we get involved. Usually if they're not having a lot of pulmonary edema, they don't usually call us for that. It's more so just a heart issue when it becomes a respiratory and a heart issue. So for the wet and the warm means they've got good perfusion in the lungs, but they're just backed up, so the lungs are filling with fluid, versus they have really poor perfusion because the heart's not able to beat properly anymore. So they're going to be cold because that poor distal perfusion, but they'll also have that backup of fluid. So that's how we look at how things change when it comes to these patients. The other ones that we know that CPAP works for is patients with ACPE, so respiratory failure due to acute cardiogenic pulmonary edema. So with this one here, this is a patient here that had a history of cardiac failure. So this first chest x-ray here, it shows the top. There's the major vessels just above the heart. So we look at the silhouette of the heart as well. You can see the lungs look clear, the heart looks fine. But then we look 3 months later with this heart failure. You can see that the top of the heart is enlarged, because this is like when we talk about seeing that JVD with your patients with heart failure with the fluid backup. It's just been such a pressure backup that all the upper vessels have actually expanded. The heart silhouette's a lot bigger, and you can actually see throughout the lungs that now there's pulmonary edema throughout. So they've got that fluid backup all over the place, and now it's affecting their lungs. So this would probably be like your cold and wet patients. So these patients, we know that CPAP is really going to help with them because they need that support to get the gas exchange going in their lungs again. So another one as well that we look at is FPE, so flash pulmonary edema. It's referred more so as SCAPE now, so sympathetic crashing acute pulmonary edema. So this is when patients suddenly their lungs just fill with fluid. So we talk about sympathetic crashing acute pulmonary edema. This refers to rapidly developing pulmonary edema that can happen in minutes, which usually accompanies patients with acute coronary pulmonary edema and severe hypertension. So these patients may end up going into a sudden surge of sympathetic activity, leading to increased capillary permeability and fluid redistribution, resulting in hypoxia and severe dyspnea. So we look at this chart here. So it says the vicious spiral of escape. So basically their body starts overreacting. So their sympathetic system gets activated. We get vasoconstriction, which increases afterload, which activates the heart, causing fluid back up in the lungs. And also it says in the middle box there, vasoconstriction shifts blood out of splenic veins into the lungs as well. So that vasoconstriction from this overreaction of the sympathetic system basically pushes all the blood back to the heart, which the heart can't handle. So that backs up, causing impaired lung function. And of course, the patient's not going to feel very well, and they're going to become dyspneic. And this is going to be a vicious cycle. And this is where we cycle into this crashing acute pulmonary edema. So this is going to come on very rapidly. So like we used the term in the past was flash pulmonary edema. So this is something we have to act on immediately. And again, this one is CPAP's really going to help with this one as well. So some things that might show a possible benefit with CPAP. So we have hypercapnic respiratory failure due to exacerbation of COPD, basically. So the definition of this is really it occurs when the respiratory system cannot adequately remove carbon dioxide from the blood. And this leads to an increased partial pressure of gas and make your patient go into respiratory acidosis. So this is known as type 2 respiratory failure. Okay. So just to show here, when we look at this picture, so on the left, it's a normal CT scan versus on the right, it's patient with emphysema. So with that, when we look at the patient's CT on the left, we can see the lungs are very big. They're able to get oxygen in and eliminate CO2 effectively. But we look on the right, we have a patient with emphysema. So very different texture in the lungs there, much less surface area. So these patients are going to have trouble eliminating that CO2, which can build up over time and put them into that respiratory acidosis. So these patients may benefit from having CPAP placed because just the opening of the alveoli, like I showed in that scan earlier, just get more recruitment of the alveoli alveoli, open up the lungs a bit. This might allow, like according to fixed gas laws there, so open up the airway, get some pressure in, get O2 in, and thin the membrane so we get more CO2 out. So it may help these patients. That's where the possible benefit comes in of using CPAP with these patients. So some of them with unknown benefits that we have listed. So non-hypercapnic respiratory due to, again, exacerbated COPD. So basically when we look at non-hypercapnic respiratory failure, this one's also known as type 1 respiratory failure, is low level of oxygen in the body, so it cannot meet demand of the body, leading to hypoxia. So with type 2, it was that we can't get CO2 out. With type 1 is we can't get O2 in. So if we have patients that are just having trouble getting oxygen into their lungs, we could look at using CPAP as a possible, may help, we're not sure. Depends on the patient. We could also look at respiratory failure due to acute exacerbation of asthma. So again, with that, if there's a lot of bronchospasm, we lose that surface area to cut that gas exchange. So again, it all ties into that diffusion law. We have that decreased surface area because the walls get thicker because of bronchos constriction. And we may get effects of diffusion if there's a lot of blood buildup. And again, so we may be able to try CPAP with patients with asthma because then we can force the alveoli open, allow the gas to go in. And this is going to work a lot better for you because we don't have to worry about gas trapping because the patient's still breathing on their own, versus if we're using our BVM with an airway and ventilating, we have to be worried about gas trapping or like breath stacking, whatever you want to call it. This one, they're going to be breathing on their own. So it's less invasive, so we don't have to worry so much about that barotrauma. Okay. Another thing we have to think about is respiratory failure due to pneumonia. So again, going back to fix there, when we look at someone with pneumonia, you got a picture here. So this is a chest x-ray of someone with diffuse pneumonia, a lot of mucus buildup in the upper airways for sure. And this is just going to cause issues with gas exchange, right? So that increase in pressure with CPAP, the opening of the alveoli with CPAP, it's not going to get rid of the mucus. It's in their lungs. It's a disease process. But again, it may just help open up the alveoli to thin that membrane so the mucus isn't as thick, and maybe help with gas exchange, getting O2 in and CO2 out. So some warnings when it comes to using CPAP where we have to be careful. So need for advanced airway measures. Yeah, if the patient can't maintain their own airway or there's worried about aspiration, things like that, we don't want to use CPAP. If they can't follow instructions to tolerate the mask, again, if these patients are really hypoxic, they might not be able to follow commands. They really need to be able to wear the mask appropriately. And if they can't follow instructions on how to put it on, things like that, it's not going to work for us. If they can't protect the airway or clear secretion, so again, kind of ties in with the need for advanced airway measures. So if we're worried about them aspirating, we really can't be putting a high pressure oxygen mask on them if we're worried about them aspirating on secretions, or even with that, with vomiting. A big one here as well is they need to have an adequate ventilatory drive. If they're not breathing on their own, CPAP's not going to fix that. We can't just cram air into their lungs and hope it works. They need to be able to breathe on their own. If they're unable to breathe on their own because they're just too tired, they don't have adequate ventilatory, you're probably better off assisting ventilations and using your PEEP with your BVM. If the patients improve enough where you can switch to CPAP, absolutely you can give it a try, but they have to be able to breathe on their own for this one. If they're actively vomiting, I think this one just makes sense, right? They've got a high pressured oxygen mask on and they vomit into it, it's going to get rammed right back into their lungs and they're going to aspirate. So if you think that CPAP's the best option for your patient, but they're vomiting, so you can consider antiemetics beforehand because, yeah, it's not safe for them if they're going to vomit into their CPAP mask. Actual airway obstruction, this isn't going to work for choking. So if you think that, okay, they've got something stuck in their throat, if I put CPAP on, it's going to force air around that obstruction, it's not really going to work like that. So we have to clear the airway first. We have to have a patent airway to use this device. So hemodynamic instability. So with this one here, we really have to take a look at their blood pressure and perfusion before we actually put CPAP on. Because when we look at the pulmonary hemodynamic effect of CPAP, it raises intrathoracic pressure, which reduces venous return to the right heart and thus reduces preload. And this might be this is one of the benefits we want. So that way, when our patients have fluid overload, we're slowing down the blood flow return to the heart. So there's less of it backing up in the lungs because as it gets ejected out of the heart, it's not, it's sitting in the air in the lungs, but once we reduce that blood flow back, it's going to hopefully reduce the amount of blood going into the lungs so it doesn't get backed up. If you do have a preload dependent patient though, this reduction in right ventricular filling may increase the risk of hypotension. So that's something we really want to be careful. And again, like I said, it decreases that venous return, which is again a benefit. So we have less fluid in the airways, but again, if they're already poorly perfused, it's going to just make them become more hypotensive, which is obviously not going to be beneficial for our patient. So another one as well is if they have a GCS under 12, they really have to be able to sit up. They have to be able to understand. They have to be able to breathe on their own. They have to be able to follow commands. Like all this stuff is they have to have a good LOC for this mask to work as well. If that's not an option, then again, you could also look at using your BVM with your PEEP as opposed to using CPAP. Obviously, laryngeal trauma, if their trachea, their larynx are damaged, we can't use this. And moving on, there's some more. So another one we have is a basal skull fracture. So just the reason why we don't want to use CPAP in a basal skull fracture, this is a CT of a patient with pneumocephalus. So they got air within the cranium. So this patient did have a traumatic head injury. They didn't think much of it. He had a bit of a runny nose for a while. Then they thought it was just a runny nose. It turns out it was cerebrospinal fluid, and he actually had a small fracture in his lower, I guess, in his basal skull. So over time, he used his CPAP, his nasal CPAP every single night while he was sleeping, and over time, it just jammed more and more air into his skull. And as you can see, this is the result. So basically, he's got a large air buildup inside his skull, crushing his brain. So this is why we don't, if we have any concerns with basal skull fracture, any severe facial fractures, things like that, we can't use CPAP. Okay, because this is a rare thing to happen, but it's definitely something we don't want to do. Other things as well, obviously if a pneumothorax, if they've got pressure damage in the lungs, using a CPAP is just going to make it go faster and turn into a tension. So we're going to stay away from CPAP with patients with pneumothorax. Any recent tracheal, esophageal, or gastric anastomosis. So this is basically they've had some kind of surgery where they've had loops of the intestine or blood vessels or other channels. They're damaged, they've been removed. CPAP can put pressure on these sites, and it can actually cause like damage to the actual surgical site or degradation of the sutures. So any kind of recent surgery in the upper airway, we're going to not use this. Same thing with upper GI bleeding. So this picture here, this is a picture of a patient that actually had a bleeding ulcer. And again, just the home CPAP, so they use it every night. So after what happened was this patient was using their CPAP every night, and they did have that bleeding ulcer, and CPAP pushes air in the lungs, but it also pushes it into the GI system. So with that, over time, he actually had air get pushed into his open stomach ulcer. And basically what happened was now he's got air inside of his digestive system. So he's got emphysema of his GI. So yeah, not the most common thing, but this patient did present with coffee ground bleeding. And when they looked at it, this is why. So that's all air inside his GI tract there in his stomach. Other things as well, facial head or chest trauma, like I said, like if their face is smashed, they can't use CPAP, and basal skull fracture for sure, don't use CPAP. Epistaxis, it kind of goes again into the same thing as the vomiting. If they've got a lot of blood coming out of their nose consistently, we put CPAP on, that pressure is just going to push it back, and that's going to cause choking, trauma, discomfort for your patient, especially if they're getting blood pushed back, and your stomach can only handle so much blood, so they're going to start vomiting. If they're hypotensive, so if they've lost a lot of fluid, again, like whether that's blood loss or whether that's just fluid loss because excessive diarrhea, vomiting, stuff like that, that puts them at risk for low blood pressure. And again, like I said before, CPAP is going to affect their blood pressure, so we don't want to use CPAP unless we can get their fluid up first, of course. GCS, so if it's slightly decreased, like again, if it's just, they just keep their eyes closed, but they're alert when you talk to them and everything, then that you could probably get away with using CPAP. But again, they have to be able to sit up, they have to be able to maintain their own airway, they have to be able to follow commands for CPAP to work. So it's a caution. Recent gastric surgery. So with that recent gastric surgery, like we talked about with the previous patient with the bleeding ulcers, it does run the risk of pushing air into that gastric area and getting into the tissues and causing like basically air buildup inside the tissues. And if the patient has intestinal ileus, so what that means is that with intestinal ileus is that there's no movement of the colon, the bowels, things like that. So basically there's minimal movement inside the digestive system. So this picture here is a patient that has what they call CPAP belly or aerophagia, where they basically got air trapped inside their GI system. So that's a gigantic air bubble from the patient's CPAP. Again, a lot of these patients, they get these, it's over time. But again, if we're being aggressive and giving a lot of CPAP, we're just shoving that air in there versus these patients that use their nasal CPAP on a nightly basis. But either way, like the air goes in there, and normally if we got CPAP and it goes in our stomach, our body will process it out and they'll burp or they'll fart. But these patients, it just gets stuck in with these large bubbles in their intestines. So yeah, with that, we can, again, it's risk versus reward. If the patient can't breathe and we get a little bit of air in their stomach, that's okay. We need to get them breathing first, but if you're going to be using this for a long period of time, it is a consideration if you start seeing distension of their belly. That's obviously not what we're going for here. Okay. So with that, that's how we use CPAP. That's when we use CPAP, and that's what CPAP does. So now we're going to go over the Rescuer II CPAP system itself. So these are going to be newer masks that are going to be put into place relatively soon. And this way we're going to be standardizing our CPAP mask use across the province. So with the Rescuer II CPAP system, we have our components. So we have a pre-attached bonded headgear. So this is basically what's going to keep it on the patient's head. We have our adjustable mask. So this is the nose piece here that can go up or down. The big thing is when we use this mask, make sure it fits properly because you need that good seal. So pulling it tighter isn't always beneficial, but the nice thing is with this adjustable nose piece, you can make it sit a little bit better on the bridge of the nose. That way you don't have to tie the straps way too tight, because if your patient's really uncomfortable and you've got to just wrench to their face to get a good seal, they're not going to want to wear it. So we want to try and make it as comfortable for them as possible. So we have the exhaust port leak valve. That's not something we're going to have anything to do with. It's just, I think that's the biggest question to get asked is what are these are for. Those are just there from remnants of other uses of the mask. So we just kind of leave them as is. So the other thing as well is we have on the actual CPAP system here, we have a manometer on the side, which is really great. So this shows you how much PEEP you're giving your patient there. So I'll have a video on it shortly, but this basically shows how much pressure is being given when the patient breathes in and out. Okay, so the other thing as well, we have an MDI medication port. So for here, this part, we just take the top off and that's where we put our MDIs. Like I mentioned before, it has a manometer there. So that's the one I was mentioning there. It shows you how much actual pressure you're getting with each breath. And this is the big one here. So we have a nice HEPA filter, so we don't have to worry about aerosolization of, patient possibly has pneumonia or anything. We don't have to worry about that getting aerosolized. Other parts as well. So we have the oxygen tubing. So this is actually attached in. We don't need to attach it. It just gets attached to the O2 tank. We don't need to attach it to the device as well. It's already preset on there. We have an extra oxygen port. So this extra oxygen port is only to be used if we're using the T-piece nebulizer system. So your 2mm oxygen tubing there would be used for using your CPAP. The extra oxygen port would need a secondary oxygen resource to put there to run your nebulizer. So that's what that green cap one is for. And we have our oxygen CPAP pressure guide. So this one's really nice as well because this is all just oxygen driven. So as you can see here, it goes by how many liters for how many centimeters of water pressure. So 5 liters of oxygen gives you 5 centimeters of water pressure. 6 liters of oxygen give you 6 centimeters of water pressure. So it's really great use. So as you can see here, a little bit closer, so 5 gets you 5, 6 gets you 6, and then we keep going up. And the max we go to is 10 centimeters of pressure with these devices for our care maps or our guidelines. And so that'd be 8 liters of oxygen. So the nice thing about this is, just not promoting the system at all, but it has been proven to use the least amount of oxygen out of the other masks that are available on the market. So which is definitely beneficial for us because it'll save us having to change out oxygen tanks as often. So how to use CPAP. So with that, the first thing we're going to do is make sure our patient doesn't have any contraindications. We're going to make sure our patient can cooperate and is comfortable wearing the mask. And we're going to make sure that's beneficial. So check your blood pressure, make sure there's no contraindications. So with that, once we've got it set up, we are going to actually put on our patient.
Choose between the small, medium, or large size mask that will provide the best seal between the bridge of the nose and under the chin. You'll want to avoid a mask that presses in on the eyes. Turn on the oxygen cylinder to confirm adequate oxygen supply. Connect the oxygen tubing to the regulator and increase the oxygen flow to 5 liters per minute. This should achieve 5 centimeters of water CPAP pressure when the mask is placed on the patient. Place the mask over the mouth and nose, making a snug but not tight fit over the face. Slide the headgear over the back of the head, positioning the lower straps under the ears. Adjustments for optimal fit can be made using the hook and loop fasteners on the straps, as well as on the forehead pads at the nose piece. The manometer reading will fluctuate between inhalation and exhalation. Measure CPAP pressure at end exhalation or just before the next inhalation. Lack of pressure means you should verify the oxygen supply, all connections, and sources of leaks around the mask or accessory ports. Choose between the
So for the procedure itself as well, so once we've got our patient cooperative, and it takes a little while for them to get comfortable, so just make sure you're constantly counseling them, telling them, okay, it's going to be really hard at first because there's going to be that pressure gradient shift and they're going to feel like they're basically drowning in oxygen. So we want to coach them and just tell them to keep breathing. Eventually, once that pressure gradient shifts, they'll be more comfortable and it'll definitely help with their breathing. So we want to watch carefully for evidence of improvement or deterioration. So again, if we've got this on and we notice that their blood pressure is dropping or their breathing's not improving, we may have to take the mask off, or we may have to look at increasing the amount of CPAP we're using so we can turn up our oxygen like I showed you on the scale there. So we might have to go up to like 6 liters, things like that. Maybe they just need a higher level of pressure to help them out. So we're going to, again, monitoring work of breathing is huge. So if they're becoming just fatigued and they've been like struggling to breathe all night, we get there, we put the CPAP on, they just want to be gas in the tank to keep breathing at that rate with that amount of effort. We want to keep an eye on that because again, they have to have a functional breathing rate on their own for this device to work versus using a BVM with our PEEP. We have to make sure we're checking their LOC, make sure you check your vital signs. Like I said, hypotension is probably a big one we're worried about with these. We always want to keep an eye on those to make sure that they're not getting hypotensive. We also want to keep checking to make sure there's no pressure leaks, anything like that. Make sure the mask is still fitting properly, especially when we're moving them from like the house to the stretcher to the truck. Things get moved, things get pulled, oxygen tube might get pulled. So we want to make sure that the mask is still fitting comfortably on the patient's face and is still working effectively for us. So one thing that some people like to do is we want to keep an eye on our end tidal CO2 on these patients to see how much CO2 is coming out and how much O2 is going in. So one thing is, as you can see in the picture here, we want to be very careful when we're using it. We don't want to use the end tidal with the tube here, because as you can see by the arrows, what's going to happen is you're going to get end tidal CO2 washout. So what that means is it creates an artificially low reading of end tidal CO2 because that device that's picking up your end tidal, when the patient breathes out, that CO2 gets mixed up with the 100% O2 that's getting put into the mask under that pressure. So when they breathe up, you're getting a combination of the two. So you're not actually getting a true end tidal, you're getting a decreased one. So if you all of a sudden you have your end tidal like this and you notice your end tidal is dropping, that could be why. So this is why we don't recommend using this form of end tidal CO2. If we're going to use end tidal CO2, we recommend using the nasal cannula end tidal CO2. So this would obviously have to be put on before we put the mask on. So we would calibrate it. We wouldn't add oxygen to this one. We'd use the oxygen from the CPAP, but we would just plug it into the Zoll and zero it, then apply it to the patient like this first before we put on the mask. So once we've done that, we put the mask over top, and this is going to be a lot more accurate because it's not having that washout where it mixes with the oxygen that's in the mask. We're getting readings directly from the patient. It's picking up from their mouth and their nostrils, so we're getting an accurate reading. So with this one, you may get a bit of a change in there as well. So with that, you may get, you may get a sudden change in your waveform. So with that, you may get a sudden increase because they're washing out their CO2. So with that, that'll level out, and so we just maintain that mask seal. If we're going to use the MDIs, so as I mentioned before, we take the red cap off there to use this medication port. So again, we could have our end tidal on, we can give medication. So you just pop that red top off there, and as you can see here, we take our MDI, and then we insert into the port. So we'd prime it first, put it into that spot there, take off the red cap, spray whatever the dosing medication you need, and repeat as required. But the big thing is once you're done and you take the MDI off the device, make sure you put that red cap back on because you will lose your airway pressure if you leave that red cap open. When it comes to the T piece I was mentioning earlier, and this is where we use the green oxygen tubing, we basically put the T-piece adapter. I don't believe this is something we're going to have in our ambulances, but it may be something you come across in facilities. So basically, the T-piece nebulizer goes in between the mask and the CPAP device, and then you would need a secondary oxygen source to attach to that green cap there. And with that, again, the CPAP is done through the main line, and then your secondary line would control the aerosolization through the nebulizer, okay, as you can see here. Okay, so for the liter flow on the green port is per the manufacturer, says use 7 liters per minute to drive the nebulizer. But again, our CPAP oxygen will be whatever we need to maintain that good airway pressure for our patient. So we immediately discontinue CPAP if patient becomes hypotensive. I brought this up a couple times. If the blood pressure starts dropping, we need to make sure everything's perfusing, so we'll have to discontinue it. If they start vomiting, obviously they vomit into an active CPAP mask, that's going to huge risk of aspiration there. They become unresponsive, decreased LOC, if they become agitated or uncooperative. So it's kind of with the decreased LOC, like I mentioned before, if they stop breathing on their own, obviously this isn't going to work. So we're going to stop doing CPAP. And the big one is with agitation and cooperative. A lot of times these patients become agitated and uncooperative just straight up because of hypoxia. So it could be that CPAP's working, but not fast enough that they're still getting hypoxic, and so they're uncooperative, agitated because they're just hypoxic. So with that, we don't really treat it like an agitated patient like we normally would. So we don't recommend sedating these patients. We need to deal with the hypoxia first, and then hopefully that will get them more cooperative. And then once we do that, we could look back at, if we can go back to CPAP or if that's just not an option anymore. But yeah, the first go-tos for these patients would be obviously they're hypoxic. That's why they're agitated and cooperative. So we're trying to deal with that first before we start thinking about medazing them or sedating them because they're uncooperative. So if we want to take our patient off CPAP, so let's say they're starting to get better, we're getting close to the facility, they've perked up a lot, the crackles have all gone out of their lobes, we can slowly wean them down. So if you had to turn your CPAP up to 8 liters of oxygen to get your CPAP pressures where you want it, we're not going to just immediately turn it off. That's going to cause a huge pressure gradient shift. So we're going to slowly turn the O2 down and just see how it works. Because again, if we take it from 8 liters to 5 liters and they start getting crackles again, we may not be able to discontinue it. It might still need that higher pressure, but we need to do that slow to keep reassessing our patient to make sure it's working for them. Another big thing as well, so this is all disposable, so make sure you dispose of all the equipment properly. When you get to the facility, make sure to do your hand hygiene as appropriate, and make sure you document your procedures. So with that as well, whenever you document, make sure you put in if you had to change your pressure gradients, if you had to give medication through the MDI, that all needs to be documented as well. And of course, patient presentation pre and post use of CPAP, whether it worked, whether it didn't, and if you ended up not using it, why you discontinued CPAP. And that is a presentation on CPAP and the introduction to the Rescuer II CPAP system. Thank you very much.